Can you all hear me clearly?
Yes.
Perfect.
Okay. Hello, everyone. Welcome to this webinar hosted by the Health and Human Rights Institute of the National Center for Civil and Human Rights. This is the fifth installment of the Health and Human Rights Institute's web series devoted to addressing mental health disparities. Today, we will discuss human rights, HIV, AIDS, and mental health, and we have an insightful presentation planned for you. This virtual series is made possible through the generous sponsorship of the National Black Talk Association for Education and Talent Development. My name is Maya Watson, and I bring you greetings on behalf of the Health and Human Rights Institute. I would like to welcome each of you today, and we hope that you are doing well at this time. We would like to clarify that the thoughts and ideas expressed today are those of each individual. They do not reflect the views of the National Center for Civil and Human Rights, nor any of its agents, employees, or components. We invite our attendees to ask questions through the Q&A link option on Zoom, and then we will pose those questions to our panelists during our question and answer period at the end of this event. We will be discussing the correlation that exists among people living with HIV and AIDS with the increased risk for experiencing behavioral health disorders. To aid us in this discussion, we have a wonderful panel lined up. First, we have Dr. Angelica Fugerson. She is the City of Atlanta's first Chief Health Officer, and she is serving in the office of Mayor Keisha Lance Bottoms. Welcome, Dr. Fugerson. Next, we have Lynnette Allen. She is the health educator for Fulton County government. Thank you for being here, Lynnette. And finally, we have Dr. William L. Jeffries, the fourth. He is the Associate Chief for Science in the Capacity Building branch within the CDC's Division of HIV and AIDS Prevention. Welcome, Dr. Jeffries. So Dr. Jeffries, let us begin with you. Traditional discussions of HIV and AIDS did not really touch on the impact that the diseases had on mental health. Has the discussion evolved to include information about the mental and emotional toll that the diseases have had on individuals? And what are some of the mental health issues that people living with HIV and AIDS experience?
Thank you very much, Maya. Yes, of course, the discussion definitely has evolved to be more sensitive to both the impacts of HIV on mental health related conditions, as well as the impact of mental health related conditions on HIV infection. And thankfully, much of that conversation has evolved due to the more research that we've been doing over the past, I'll say, 20 years, or more so in the past 10 years, that is attempted to address more so the contextual factors that place persons living with HIV at risk for premature mortality, as well as HIV-related morbidity, things such as opportunistic infections and other chronic diseases. But also research that has addressed some of the contextual factors that make persons living with HIV vulnerable to being infected in the first place. And certainly Dr. Judah Fugerson has done more of that type of research than I have. But we do know that research is having an impact. It's not nearly as great as it needs to be. We definitely need more attention focused on HIV in relation to mental health conditions. But thankfully that work has begun. And to some degree, a small degree, it's supported by the federal government. As you all know, that the National Institute for Mental Health, by the hundreds of millions every year, funds research related to HIV, and some of that research does, to some small degree, address mental health problems. And certainly at the Centers for Disease Control and Prevention, where I have the privilege of being right now, we have conversations oftentimes about mental health in relation to HIV. And when you ask second about some of the issues that disproportionately or really affect persons living with HIV, those mental health conditions, that is, all in all, they're not all that different than the issues that affect the general population. We know from the research that depression, anxiety, for example, are greater among persons with HIV. The challenge with HIV, however, is that it itself is a health condition. And when an individual is at risk, already has HIV infection, but at risk for experiencing mental health conditions, it can have very profound effects on their ability to acquire and maintain good health. And we oftentimes discuss that with regard to medication adherence. As you and many persons in the audience know, adhering to HIV antiretroviral therapy can, effectively assure that there is no risk for HIV transmission if that person with HIV acquires viral suppression, which nowadays is relatively easy to do from a medical perspective. And so when mental health challenges persons' abilities to take their medications or to acquire viable employment, maintain that employment, have a mindset in which they value themselves to the extent that they would like to seek out treatment and ancillary services, then that can definitely affect outcomes that we attempt to address by way of public health and medical interventions.
Thank you, Dr. Jeffries. Appreciate that response. Lynnette, Allen, as we've just discussed, there is a direct impact that HIV and AIDS have on an individual's emotional and mental health and well-being. Research shows that individuals who maintain good mental and emotional health and stability have better coping mechanisms to deal with the ongoing physical effects of a chronic disease. What coping mechanisms would you suggest for persons living amongst this community? Lynnette, are you there? Dr. Jeffries, why don't you touch on some of the coping mechanisms that individuals can rely upon to help deal with the effects of HIV and AIDS?
Sure. For persons living with HIV, the research shows that, like the general population, persons make use of various types of coping strategies to deal with not only the infection, but some of the outcomes related to infection, particularly the negative outcomes related to infection, such as being potentially ostracized by your family or community or religious organization, potentially being not being, deemed as someone who can have a healthy sex life. And so much of my research has focused on religion and spirituality. And that research, along with other studies, show that persons with HIV, and it's especially true for African Americans more so than any other racial ethnic group, use to a great extent prayer, Bible readings and motivations, and acquiring support from one's religious community as a way to deal with the infection, and also to see in a holistic manner one's ability to live in community with others, and understand that also has an impact on our health, because we certainly, from a basic human perspective, need social support to live viable, healthy lives. And so those definitely are some of the strategies that are used with regard to religion and spirituality. But also people living with HIV oftentimes use other strategies. Social support groups, for example, are commonly used by some particularly vulnerable persons with HIV. And so it's encouraging to see persons with HIV take advantage of those. But the challenge is that because HIV is so stigmatized nowadays, it presents a challenge with regard to the extent to which persons with HIV might be willing to use coping strategies that could potentially be helpful for them. And unfortunately, some persons with HIV in our communities, African Americans, rely, due to no fault of their own, on substance use to cope with HIV infection, the stigma associated with infection, and negative outcomes associated with infection. And studies clearly show that among gay and bisexual men, the population I study most, substance use is elevated in general, but especially high for persons with HIV. Marijuana is commonly used, very prevalent among African Americans as a strategy for coping with HIV infection. Thankfully, based on what we currently know from the research, marijuana definitely does not have nearly the deleterious effects on one's physical or emotional lives as other, quote, hard drugs might have, things such as cocaine, methamphetamine. But methamphetamine use, which is, methamphetamine is a dangerous drug. That has increased over time among all gay and bisexual men. and has notably increased among African American gay and bisexual men as well. We don't see much methamphetamine use, at least not from a comparative perspective, among other populations, such as heterosexual men and women. But we see it being especially common among um, gay and bisexual men and other sexual and gender minorities. And so it definitely warrants our attention with regard to how we promote healthy coping from a public health and medical perspective, but also
Absolutely.
ensure that the resources that need to be in place for us to effectively cope if we in fact have HIV are there, and that we are can use them and not feel stigmatized for using them.
Thank you so much, Dr. Jeffries. And some of those points you brought up, religion and spirituality and a strong social network, those are very key, as you mentioned, in dealing with mental health disorders across the board, especially for Black and Brown people. So thank you for that. Dr. Fugerson, let's turn to you. The South is seen as the epicenter of a growing HIV and AIDS epidemic, with more people living with HIV than in any other region in the country. And Georgia is ranked 6th highest among the 50 states in cumulative reported AIDS cases. In Georgia, as elsewhere, the people who bear the overwhelming burden of this disease belong to racial and ethnic marginalized groups. As Dr. Jeffries just alluded to, Black men living with HIV in Georgia, the number is 5 times that of white men. And with respect to Black women in Georgia, their HIV diagnosis is nearly 13 times that of white women. So as the City of Atlanta's first Chief Health Officer, what particular steps is the City of Atlanta doing to tackle the epidemic and address the behavioral health issues that arise as a result of these cases, and also deal with the disproportionate impact of the disease? I know that's a heavy question, and you are very busy during this time for a number of reasons, and so we appreciate your time today. So thank you in advance for answering this heavy topic.
Thank you so much for the opportunity to join you all. It's so good to really see all of you again and meet a few of you. And Dr. Jeffries, it's so good to see you again as well. And just thank you for the opportunity. You just hit me hard with all the questions. So part of the reason why I was appointed to this position was because of my extensive background in HIV and AIDS research, my work that I've done around developing HIV and AIDS interventions, and all of my work has focused on addressing disparities and inequities in populations that reside in the South. And so prior to COVID, we were working on a lot of plans to really ramp up the communication and conversations around HIV and AIDS within the city, expanding our partnerships at the local, state, and even the federal levels to really look at what we know what a lot of the problems are around HIV and why we were seeing the increases in populations that continue to be marginalized. And so we were focusing a lot on PrEP and prevention. We're focusing a lot on stigma and ensuring that people understood that they do have access to certain services. And if they did not, where they could go, how they could access those resources, who they would need to talk to, and then be able to provide them with their most reliable information. We were planning a few things around our key partnerships, especially with our folks at Fulton County, and then outlining just some key messages as it relates to behavioral health and mental health in particular. So when we talk about behavioral health across the board, we were looking at multiple things that included HIV as a key component. We were having conversations and hearing from members of the community as to what they went through when they were first diagnosed and what resources they wish they had. And then looking at conversations that we were having with their family members and, you know, how they were finding ways to support their family member who had been newly diagnosed, or they were just now sharing that information. So what we wanted to do was take a comprehensive approach to finding ways to increase the availability of messaging, education, resources. We provided funding to some of the local health departments so they could ramp up some of the HIV work as well. And then we increased our partnerships at the local and state level to find ways to take a broader approach. So when you do that, you're addressing not only an access problem, but also impacting mental health within that. So when people are clear about where resources are available, and we are clear about what the problems really are, so we know, but we can't assume, and we have to hear from the community, we can have a more effective approach. So we were using a broader approach to really address multiple issues that included behavioral and mental health as it relates to aging.
Thank you, Dr. Fugerson. Lynnette, are you there?
I'm here now, I think.
Wonderful. Yes, we can hear you. Thank you for joining us. Can you discuss some of the specific steps that Fulton County is taking to address behavioral health and the needs of those living with HIV and AIDS in the county?
Absolutely. So one of the programs, this is one of our newer funded programs. It's only been with us. We were awarded about September of last year from SAMHSA. The sole premise of this program is targeting minority men between the ages of 18 to 40 who are having sex with other men, but also who are also at high risk for becoming HIV positive, or who may already be HIV positive, but also having a mental health and or substance abuse or a co-occurring disorder. In this particular program, it provides social service referrals, transportation, anything that's dealing with food, anything that would help that person maintain a certain standard of living, but also it provides education and other resources, that people that are HIV positive would need. Right now, it would be great if we would have more people enrolled, because as a part of it, we also know that when a person is retained in care, if they're coming to their medical appointments the way that it's supposed to work, we can get them to a healthier state, and we can suppress the viral load a whole lot faster, and also that would help to reduce transmission. So of course, we also, within the Board of Health, we have 2 of our clinics that provide PrEP for those individuals who are not positive, but would like to be able to access PrEP. So, and of course, we provide testing Monday through Friday and even on the weekends. Well, it used to be on the weekends until COVID took effect. But we have our mobile unit that's still out even during the COVID outbreak.
Yes,
So
well,
those are just a few of the things. But of course, like I said, we have what used to be our Ryan White Clinic, but now is HIV elimination, which works with a lot of the medical centers and resources within the metro area.
Thank you, Lynnette Allen. I appreciate that.
So
we want to, at this time, invite the audience to, if you have a question throughout the course of this webinar, please pose those questions in the Q&A link option at the bottom of your screen. So when we organized this web series, we did not know that we will be talking about one disease and the behavioral health impacts on that community of those people living with HIV and AIDS, while we were also living through a pandemic, being COVID-19, and observing social unrest unfolding all over this country. So during this time of COVID-19, I'm sure each of you is busy. Can each of you talk about how COVID-19 has affected your organizations and your targeted population? Dr. Jeffries, can we start with you?
Absolutely. As you might imagine, all of us, for the most part, at CDC, are working from home, which in and of itself presents, some challenges because productivity, is enhanced by being in close proximity with others from an organizational perspective.
Yes.
And so, COVID has slowed things down to some degree with regard to what CDC's funding recipients, so those who receive monies by way of our cooperative agreements, grants, and contracts, are able to do, because like Ms. Allen referred to, HIV testing is essential. It's what we refer to as the gateway into care for persons with HIV. But many of the HIV testing activities across the country, as you might imagine, have slowed down. They certainly hadn't ceased, and HIV testing is occurring, and it's occurring in relatively high numbers, but it's definitely slowing down due to COVID, and people simply not wanting to, be in close proximity to others, given the infectivity related to COVID-19. And so people have not, as they had before COVID, access services, which is completely understandable and what we might expect. But more than anything else, COVID has forced us to think very differently about public health and about ourselves in relation to public health. And this is true for all different types of people who work at CDC. And it makes us think differently because we realize that HIV isn't the only problem that persons with HIV have. And HIV is not the only problem that persons who are vulnerable to HIV have. I mean, Ms. Allen referred to PrEP or HIV pre-exposure prophylaxis, which is a medication that one can take to prevent HIV acquisition. But, realizing what COVID has done, and I have to name what must be named, due to systemic racism that is institutionalized in this country, that is part and parcel to what the Constitution of the United States is founded upon. It makes us realize that it really is something that we need to be addressing. And although institutionally we have not at CDC, as far as what I know, we have not attempted to intervene, so to speak, on institutionalized racism. But our agency director, Dr. Robert Redfield, my center director, Dr. Jonathan Merman, and my division director, Dr. Eugene McCrae, who's also an African-American gay man. They've all, messaged to us the importance of thinking about and attempting to address institutionalized racism, because we realize that due to the vulnerabilities that we have as people of color, broadly, Black and brown people, we will continue to have these issues if we do not address the problems that are causing the issues. Mm-hmm. An analogy I like to use is, imagine you are in your house and you have a leak that is damaging your hardwood floors. You look at your ceiling and you can see the staining on the ceiling. But the reason you have the leak is not because something's wrong with the floor or the ceiling. You have the leak because you have a hole in your roof. So why would you keep, cutting out sheetrock and painting over it for your ceiling, replacing your hardwood floors, when you could pay $10,000 for a roofing company to come out and give you a new roof, and then you won't have the problem to continue? The reason we continue to see HIV spread to the extent that it spreads is due to what we call in public health the social determinants of health, which are the underlying social factors that make people sick, literally. Things such as racism, poverty, various forms of discrimination, homophobia, transphobia against our transgender sisters and brothers. And the outcomes of those, such as low education, lack of access to health care, lack of, high SES related employment. So many of our Black and brown sisters and brothers have to go to work. Dr. Jeter and I and many people on this call can work from home. That's a privilege. But most people in our communities do not have that ability. They have to go to work. And what we have seen is the disproportionate impact that COVID-19 has had, especially on African Americans out of all people of color. And to some degree, Native Americans, although we're not having a conversation about Native Americans to the extent that we should be having in this nation. And so these are things that people at CDC definitely are thinking about, and that people on this call I know are thinking about, and nationwide with regard to our public health efforts, we're thinking about how we can really address institutionalized racism, not promote coping for African Americans. We realized for the last 401 years that we can pray. Black people are more religious and pray more than anybody else in this country. We read the Bible more than anyone else, but yet we're among the sickest. Why is that the case? Obviously, something isn't working. It's because we have not addressed the underlying causes of the problems that make us sick. And for African Americans, Latinos, Native Americans, and even to some degree, although not to the same extent, Asian Americans, that factor that we must address is institutionalized racism. not just one being discriminated against or having the N-word hurled to them, or having a police's knee on your neck, but rather the underlying structural factors embedded in the very fabric of this nation that must be unraveled if we are to tackle HIV/AIDS, which Ms. Allen alluded to earlier, affects Black women with regard to HIV incidence. 13, depending upon the year, 13 to 16 times more often than white women. That affects Black gay men and Black gay and bisexual men, according to the most recent data, 10 times more so than white gay and bisexual men. And Black people use condoms more than any other racial ethnic group in this entire nation. We have to ask why that is the case. Much of it, of course, stems from lack of access to health care. But the reason we don't have access is because we are Black. And we must address that as a fundamental problem.
Are you preaching, Dr. Jeffries? I love it.
Amen.
I love it. Thank you for that. Lynnette Allen, are you seeing some of the same issues with respect to how COVID has affected the Fulton County government, as Dr. Jeffries just mentioned? Less people coming in for HIV testing and so on?
Well, absolutely. And unfortunately, I actually don't work on the Board of Health side. I actually work for the Department of Behavioral Health and Developmental Disabilities, but we partner. This is actually my first day back in the office working since March 18th, I believe. So like Dr. Jeffrey said, we've been fortunate enough to work from home. However, the Board of Health was open in certain locations, and they were providing testing every single day, not only for HIV, but for COVID-19 as well. We are now in our second or third phase of reopening and getting our centers up and running and allowing the community to come back in and access some of the services. It's been kind of slow for us. A lot of our employees were out on administrative leave, so we were working with skeletal crews, but we're now back hard at work. And we're hoping that our clients will come back in, get their testing done, get the results, get the necessary resources that they need, because a lot of times we find people will get tested, and for whatever reason, for fear of knowing what that result might be, they don't come back, or they already feel like, there's enough going on in their world, so they really don't want to find anything else that's going to bring them down. So there are a myriad of reasons as to why people don't access the care. A lot of it is because they're not aware of the resources that are available. A lot of people will move, they're very transient, and they don't always find the resources that are available. So a lot of it is, even now, we still have a lot of education to do.
Yes, thank you, Ms. Allen. Dr. Fugerson, would you like to weigh in on that question as well?
Absolutely. So COVID shifted everything that we were doing. We had a huge focus of some big plans, partnerships that were lined up and were actually set to begin the week that the very first case came to Atlanta. And so in the midst of that, we had to put a pause on everything and create new protocols, guidelines, figure out what kind of data we wanted to use. We had to, advise the mayor on when to shut down the city and what would be most effective. Looking at what key components and what's been successful in other cities and even other countries, reaching out to our local and state health departments, because what a lot of people don't realize is with the city of Atlanta, we don't lead the health departments. That's done at the county level. Mm-hmm. So partnership is essential to everything that we do so we can be successful and we can really be effective. Mm-hmm. And so COVID shifted how we have to implement everything. This is the first time that I've been in my office probably since early March. And the only reason why I am at City Hall right now is because I and the rest of the mayor's pandemic coordination team stood up a COVID testing site for our first responders who have been involved in assisting with the demonstrations. And I mentioned earlier to you, there's protesting that's happening outside of our office right now.
Wow.
And so we're in the midst of, we've kind of gotten a system in place with our COVID-19 response to support the mayor and all of her efforts and the rest of our administration. But now we're having to think about mental health more broadly. So we held the mayor's first emotional wellness summit for women back in February. It was our very last big group gathering in 2020. And so we provided resources to women and their families within the community. And we've realized that these resources are now helping women as they go through this process of potentially being isolated, figuring out how they're going to respond and, you know, try to get some sense of normalcy in the midst of COVID. And it's shifted how we had to think about how public health is implemented at the city level. And when we talk about HIV, we're thinking about people who, you know, could have a compromised immune system and how COVID could affect their risk. We're thinking people who are even more vulnerable because of the social determinants of health and effects of racism. And then, you know, the political uprising and changes that are happening right outside of my office right now, and really trying to make sure that we're present and listening to the community in the midst of all of that. And so as Chief Health Officer, my goal has really been focused on lifting up their messaging around mental health. On our atlstrong.org website, you will find a mental health section where people can find helpful information and resources, whether it's in Atlanta, in Georgia, or even across the country, because we know all eyes are on Atlanta.
And so that's atlstrong.org?
Yes, atlstrong.org. Yes, on that very, I think we've updated it. We have so many components to it now, but on the main page, you all will see some mental health information as well. So COVID has shifted everything that we're doing. We're slowly getting back to I'm getting back to focusing more on some of the work that we were doing prior to the pandemic. But at the moment, it's trying to make sure we lift up the messaging around behavioral health and mental health across the board.
Awesome. Thank you so much, Dr. Fugerson. Dr. Jeffries, you touched on some of the correlations between HIV infection and behavioral health conditions, both substance use and mental health disorders previously. Why does this correlation exist? I know you spoke about it in great detail, but is there anything else you'd like to add to that discussion about why the correlation exists there? Because I think that some people still don't understand why.
Sure. The association, that association, you know, between, you know, and you're specifically referring to behavioral health issues, mental health and substance use.
Yes.
The association between behavioral health issues and HIV exists in part due to the underlying vulnerabilities that people who are socially marginalized have by virtue of their marginalization. And by marginalization, I mean not being valued to the extent that other people are valued. So when you look at the populations that are at highest risk for HIV infection, gay men, of course, being at highest risk with Black gay men at even higher than all others, African Americans and Latinos, we are populations who deal with a lot in life. And the same factors that promote behavioral health problems are the same ones that promote HIV infection, with access to care being one of them. It's important to note that in the United States population as a whole, Black and brown people do not have, according to most data that are published, do not have, well, are not more likely to have mental health conditions than white people. Well, most, and that's from, I mean, the big ones, anxiety, depression, namely. The problem is that Black and brown people are much less likely to have access to care to deal with those issues. And historically, we have had a great deal of stigma in communities of color around accessing mental health care. Arguably, no community has had greater stigma about this than African Americans. And part of that is due to religiosity. The fact that when we get sick, we are taught to pray, take it to the Lord in prayer. Baby, the Lord will make it all right. The challenge with that is that we oftentimes do not access the services that are available, don't know about these services. And that's because we have this underlying assumption that somehow we're spiritually or socially at a deficit if we were to seek out those services, because we're supposed to be able to handle it on our own. We're strong Black people. We should be able to handle it on our own. And we should be able to, pray about it and God will make it all right. And that, although, prayer and meditation, all types of religious practices are very important, that's not going to solve the problem. As an African-American man who accesses, psychotherapy every month, and who accesses, I go see my psychiatrist every 3 months, not because I have a problem, it's because I don't want to have a problem. Right. And after seeing so many Black gay men, so many Black transgender women commit suicide, see so many African-American cisgender women crumble under the pressures of life, I made the determination that I, as a very, spiritually informed person, would take advantage of the resources that are at my disposal, because they're at my disposal, and it's important for us to take advantage of those services. And by, interacting with people like Ms. Allen and Dr. Gita Fugerson, realize what those services are and realize that they're there for our benefit.
All right.
I would like to add on to that.
Yes.
So yes, there is no one that I know that is more spiritually led than Dr. Billy Jeffries. I can honestly say that, anytime I hear him speak, I feel like I'm in the middle of church and the spirit is being moved. So thank you for sharing that. I think that during this time with COVID, people are dealing with behavioral health problems and issues and experiences that whether they had sought services prior to, or if the isolation, the fear, limited access to whatever they needed bubbled up some other things during this moment. I think it's been very different for a lot of different people. And there is more access than we realize. I've been very surprised by the number of resources that have been made available as it relates to behavioral health and mental health services during this time. And I would say, now it's making me think of some other things that we can add to the website, but I would say, go online and visit the National Alliance on Mental Illness. I believe NAMI is the acronym, but they have some great resources that are available for people to check out. And I think that tapping into your social support system, your friends, your family members, or joining groups online is very helpful. I think that I know that there are great websites like Therapy for Black Girls. They have a long list of people who you can this is a pandemic. We are in a global emergency. And I think that grace with ourselves and patience is so essential during this time, because we are experiencing things that we have never seen before. When I say, I mean collectively, everyone on this call, our friends, our family members, all of this is so new. And so as we respond at the local, state, and federal level, we are trying to find ways to empower, not only support, but empower members of our community to be their best selves, even in the midst of a global emergency. And so I hope that with everything that Dr. Jeffries said, anyone who is on this call would either tap into those resources or share the resources that we have shared with you, to let you know.
Wonderful. Dr. Fugerson, while you still have the microphone, how can individuals receive the emotional and mental health services that they need when they're likely up against compounded stigma, right? So the stigma of living with the disease on top of the stigma connected with seeking mental health treatment, especially if they belong to a marginalized racial, ethnic, or LGBTQ group?
Part of it is a couple of things that people can do. I know that some people are not ready to be, they are focused on the stigma. There is a level of fear, there is a level of shame. And I think that I know that there are some organizations that offer, numbers that you can call. You can speak with someone anonymously if that's where you are. The other piece is hopefully people can get to a place where they have a strong support system. They can tap into those networks and have those trusted people that they can have some conversations with. I think those numbers, there are even, conversations you have with therapists via text message. There are even apps that you can download that offer certain resources through, I think through Calm, a couple of other organizations that offer meditation. There are a number of things. I think during a time where the world is having to be innovative in their care, we can look at text messages, phone calls, apps that are available, tapping into online support groups that are available through social media platforms like Facebook, Instagram, and even on Twitter.
Yes.
There are multiple these celebrities who have established mental health resources that are available and free for people to tap into certain things. And everything that I'm mentioning, I'll send you a list and you can share that with people who join the call. But I think that it's important to not put the onus and pressure on addressing stigma for people who are trying to seek services. I think it's important for the providers to address the stigma that they may exude out into the world, you know what I'm saying?
Yes.
So that they can be more invited into the welcoming space for the people who want to seek the services. Very oftentimes we put the pressure on members of our community without holding providers, public servants, politicians, so on and so forth, accountable for the environment that creates the stigma. So I think that's an important piece that has to be said, and as well as addressing our own internal stigma and, troubles that we may have, because there is no shame in trying to be your best self.
Yes, that's right.
But I think the onus is more so on the providers as well.
Wonderful. Thank you, Dr. Fugerson. Lynnette, we've been talking about intersecting vulnerabilities in people who have or are at risk for having HIV, who are already vulnerable to mental health conditions, and may face other challenges. So they may fall into the domains of certain socioeconomic groups, social structures, societal stigmas, and poverty, educational status, and things like that. How can society as a whole address the behavioral health of people with those intersecting vulnerabilities?
When we're talking about mental health as a community, as a society, we have to realize that there are no perfect beings. We all have some issues, whether it's physical, mental, or both, and we have to be honest with our loved ones, as opposed to ostracizing people because maybe they're a little different and maybe they don't think the way we do, or maybe there is a mental health or a behavioral health issue. We have to understand why they're so compounded, and a lot of times it dates back to early childhood. It could be because of trauma. It could be because of a natural disaster, but whatever it is, if that issue is never addressed, even in childhood, that adult will grow up and continue to think a certain way. And a lot of times we're taught by our family members, again, because of shame, because of stigma, you don't have a mental health problem. There's certain words that we're not supposed to use. And of course, when people go and seek treatment, if they're feeling a certain way about that provider, they should address it, because not every provider is going to be the best for that particular individual, but also just letting them know, I'm open. I don't mind coming in for treatment, but allow me to see someone else. There's so
Okay.
many ways it can be addressed, but of course, on a local level, on a state level, when it comes to voting and using our votes the right way, making sure that those platforms that we really care about, that we pick those candidates who are going to help to support and fund our needs, especially when it comes to funding for healthcare, whether it's behavior or physical. Here at Fulton County, we provide services, especially for behavioral health as well as the public health side, for those who are uninsured or underinsured. So our doors are always open, and we take any and everybody. We address behavioral health, substance abuse disorders, as well as the mental health needs.
Thank you so much, Ms. Allen.
You're
Dr.
welcome.
Jeffries, you spoke about this earlier, you and Dr. Fugerson, but there is evidence suggesting a bidirectional relationship between depression and the immune system. Depression is known to negatively affect the immune system and result in an increased risk of mortality among those living with HIV. Does this point toward a need for universal mental health screening that should be integrated into HIV care?
I'm not certain that that particular relationship points to the need for universal screening, but overall, based upon what we know from public health and medical research and practice, by all means, definitely for persons with HIV, we should be universally screening, because we know that it impacts the outcomes, it meaning mental health, adverse mental health conditions, impact the outcomes that we are seeking to address by way of our HIV prevention efforts, namely medication adherence, which leads to viral suppression, and as a result of viral suppression, the inability to transmit HIV to someone else. And so definitely that should be something that providers should be doing, whether they do it by way of formal or informal mechanisms. And always providers should be thinking about mental health and other contextual factors that will impact their patients' or clients' abilities to acquire and maintain good health, not just viral suppression, but better health holistically, for the whole body, the whole mind, the whole spirit. And by doing, more screening, even if it's not universal, which would be potentially a good thing, but if more screening and a lot of screening for mental health occurs, mental health related conditions occur, then that could have an impact.
Awesome. Thank you, Dr. Jeffries. Dr. Fugerson, housing instability has been linked to reduced treatment effectiveness. And studies have shown that housing stability is positively associated with increased HIV medication adherence. Are there any steps that the City of Atlanta is taking to increase housing stability among the population of those living with HIV?
There have been a lot of updates and changes as it relates to what we're doing around housing and HOPWA, housing stability across the city in general. We have a lot of major initiatives and funding that we are plans for funding that we're putting forward as it relates to housing. And I know that there are some shifts that are happening as it relates to HOPWA. I don't lead our HOPWA efforts. That's probably within the grant office. But what I do provide is key resources and information around exactly what we're talking about. Some of the disparities, the stigma. I offer the public health lens as those decisions are made, so that we can ensure that the city and the people who are making those decisions have a clear understanding of what it is that we're impacting, what members of our community are facing, what are the social and structural barriers and issues that contribute, and how when housing is not consistent, steady, and not just consistent and steady housing, but safe housing, quality housing, is not available, the impact for someone who is HIV positive. So there are a lot of efforts that are being outlined, and I think that information is available through our atlantagA.gov website. And there is an entire section around housing, and you can see our One Atlanta initiatives and plans that have been laid out that relate to housing in general in Atlanta. And then there is a section around HACWA, which focuses on members of our community who are HIV positive.
Wonderful. Thank you, Dr. Fugerson. And I want to thank each of our panelists who are heavy hitters in the behavioral health and the health community as a whole, not just in Georgia, but across the country. So if you have attended this seminar, you are very lucky because this was a very powerhouse panel that we had today. So we're very lucky to have them. Please join me in thanking them for their time, for their commitment, for their love for the community. I want to thank each of them. And so we want to move to questions from the audience. We have one question from Sierra Bowen. She asks, since COVID, has there been any increase or decrease in the number of HIV cases that any of the panelists know of? And also, has there been an increase in mental health issues since COVID, with people not being able to have that social aspect and social support that is needed to help with mental health issues? Would any of our panelists like to answer Sierra's question?
I can tackle the second piece. I no longer have access to the HIV data that I used to have access to, but what we do know is that we had a lot of members of our community reach out to us on ATL 311 to ask about mental health services. They talked a lot about the impact of being isolated, the fear of getting COVID, and just fear that if they are asymptomatic, how they could potentially infect one of their family members who was a part of the vulnerable groups that we've outlined within our guidelines. So I think that within the conversations that we've had, there has been a tremendous mental health and behavioral health impact based on COVID. Another thing that I've been thinking about is how our leaders are coping during this moment, because you're juggling a lot of key components around keeping cities safe, working with essential workers who are keeping the city going, especially when the city of Atlanta has not formally opened, but during the time when it was so much uncertainty. And so having to address anxiety that people were feeling as well. So absolutely, definitely there has been an uptick around mental health questions, wanting to seek services, and then even me working with the rest of our senior leadership to say, we're working nonstop 24/7, make sure you check in with yourself and your mental health specialists.
Thank you, Dr. Fugerson. We have another question from someone who said, it was mentioned that Black men and women are more likely to have HIV and AIDS, but they also use condoms more than white men and women. Can he elaborate on this? And I think the attendee was referring to Dr. Jeffries, your comment when you mentioned this, but you also mentioned that this irony often results because there's a lack of access to healthcare for Black women and men with respect to other populations in the country, and also the social determinants of health. Is that correct, Dr. Jeffries?
Yes, that is correct.
Okay.
And so, Ms. Sierra Bowen, inquired about, increasing or decreasing HIV cases. I must say that I do not know if HIV infections or diagnoses have increased since COVID-19. I am not aware of any, I do not know if any of my CDC colleagues know either. And part of the reason for that is how we do public health surveillance, and specifically HIV surveillance, which takes time. And generally speaking, from a nationwide perspective, we have not had enough time to know what's been happening in terms of HIV incidence, meaning the number of new infections that have occurred over a period of time. So that is the answer to that question. With regard to the inquiry about Black men and women in condom use and its relation to HIV infection risk, the again, the factors that promote health, although we've been conditioned to think otherwise, the factors that promote health more so than any other factors are the social determinants of health. The conditions in which we as persons of color and persons who are sexual and gender minorities live. And I can illustrate that best by describing what we've seen occur among Black women. And again, Dr. Jeter Fugerson has done more research in this area than I have. But we have, at least in 2018, the HIV diagnosis rate among Black women was 13 to 14 times as great among Black women in comparison to white women. The reason we have that is that there are underlying social factors that, due to racism, make it so that Black women don't have the same type of access to partners as white women would have. For example, we know from criminological research that Black communities are more likely to be policed than white communities, clearly, and we all know this. We also know that Black people are more likely to be arrested if presumably a crime has been committed than white people. We get harsher sentences overall, and we get harsher sentences for the same crimes that white people do. And so what we have seen in what Michelle Alexander refers to as a new Jim Crow is the proliferation of privatized prisons. Privatization of prisons is a $4 billion industry in this nation, which essentially means that as the number of predominantly Black and brown men are incarcerated, white men are making money. When you have Black men being taken out of our communities, it imbalances what we refer to as the sex ratio, meaning that there are more Black women in comparison to Black men. And that inevitably results in sexual concurrency, or a Black woman in this case having, a Black man rather in this case, having sex with potentially multiple Black women, which speeds the spread of HIV in a given community. Early on during the COVID conversations, you might have heard some of the experts, including Dr. Tony Fauci, refer to R0 or R sub-zero, the reproduction rate. The reproduction rate of HIV infections increases exponentially due to sexual concurrency. So that's one way. Also, think about Black people as a whole in comparison to whites in this nation. We have less access to care, and when we do have access to care, we have decades of research showing that we do not receive the same quality of care. And that results in Black people who, should be screened for HIV or any other, condition that might give rise to it, such as sexually transmitted infections, not occurring to the extent that it should. I mean, Ms. Allen, articulately described the work that she's doing on HIV testing. But oftentimes in clinical settings, Black people just do not receive the same things that white people get. And so as a result of that, our infections, and not just that, but many contextual factors, our infections are diagnosed later in the game. We're more likely to be diagnosed with stage 3 HIV infection, previously referred to as AIDS. And we're more likely to therefore transmit HIV to others. And these factors compound over time and across geographic subpopulations of Black people to promote the rapid spread of HIV, despite the fact that we have more condom use and more HIV testing. Studies have shown over many, many years that among Black heterosexual men, heterosexual women, and gay and bisexual men, the odds of us being tested for HIV over the course of our lifetime is 2 to 3 times greater than it is for whites. And over the course of the year, it's anywhere from 1 to 2 times greater. But that is not enough because we have all the structural factors stemming from institutionalized racism in this country. Not enough to prevent the spread of HIV.
In addition to that, again, going back to the providers, so you're in a situation where you have clients and patients who are experiencing all of these different levels of racism, discrimination, social and structural barriers to care. There is a lot of medical distrust that is in the system that people don't want to go out and seek care from people who are going to either be racist or they have this fear of being discriminated against. And then you have providers who don't understand the statistics, don't understand how racism contributes to limited access to care and resources, or they are also aren't comfortable with having the conversation. We recently published a study that talked about that very thing. Many of the providers are not comfortable with having the conversation around sexual health screenings, let alone talking about health. So when you compound that with a population of people who have been traditionally marginalized, isolated, discriminated against for hundreds of years, and the system is set up to keep them in that space, then it's going to go down and lead to more infections, other chronic diseases, comorbidities, so on and so on and so forth. So it's not necessarily about our behaviors, which is what we are trying to say, which is what our research has shown. We do what needs to be done, but the system has been established that keeps us infected, sick, unhealthy, so on and so, with limited access to care and treatment that we need.
Thank you. Thank you, Dr. Fugerson. Thank you, Dr. Jeffries. Thank you, Ms. Allen. Thank you to all of our panelists and attendees for attending today's very important discussion on human rights, HIV and AIDS and mental health. We are now at the end of our hour, so we definitely want to respect everyone's time. I know we had a couple of questions from Shakithra Foster. Shakithra, unfortunately, we're unable to get to your questions, but thank you for attending. We want to invite you all back for our final webinar, which will be in 2 weeks, on homelessness and mental health. And this recording of this video will be up on our website, 2020healthsummit.org, next week this time. So we want to thank you for visiting. Watch our recording. Please forward it to your loved ones and friends. And hope you all have a wonderful day. Thank you.
Thank you. You all too.
Bye-bye.
All right.
Bye-bye.
Bye-bye.